Welcome, everyone. Thank you so much for joining us today on this Thursday afternoon. I hope we find you all healthy and well. Thanks so much for listening in. We're going to cover hopefully a lot of really helpful information for everyone. We are going to get to as many questions as possible. Thank you to everybody that submitted questions online. We certainly got a bunch. So we'll get through as many of those as we possibly can. And then we'll also use that information that we covered today to update that FAQ document on our website. So please feel free to check back at that document regularly. We'll continue to update it with more information as we get it. We are not going to be able to use the chat box function today just because we have so many folks on the line. And there is a potential that some folks may get blocked out. We only have a certain capacity for the call today. So if you hear that people weren't able to get in, we apologize in advance, and we are going to get this blasted out so that it's available for folks to listen back to just as soon as possible. With that being said, we'll go ahead and dive right in. We've got some great panelists with us today. We have Dr. Jeff Auletta. He is an infectious disease and hemonc BMT doctor at Nationwide Children's Hospital. And then we've also got Dr. Seth Perlman and Dr. Kathryn Wagner, who are neurologists from Seattle Children's and Kennedy Krieger, respectively, and Dr. Richard Schell, a pulmonologist from Nationwide Children's. So at this point, I'm going to go ahead and hand it over to Dr. Auletta to give us some background information and general guidance on COVID-19.
Good afternoon, everyone. I have two roles here at Nationwide Children's Hospital here in Columbus. One is the director of the blood and marrow transplant program, and the other is the director of the host defense program, which is tailored for diagnosing and treating immunocompromised patients. So thank you for the opportunity to present. I wanted to present some background. I know this is a sophisticated audience, but the information is changing every day. So I want to make sure that everyone has the latest websites that provide the best information on COVID-19. So the first is COVID-19 stands for Coronavirus Disease 2019. It is a disease that is caused by a SARS-CoV-2 virus. So that is the virus which causes COVID-19. So we'll talk a little bit about information specific to the virus, and then we'll delve into information regarding COVID-19. So the first thing about the virus, so SARS stands for Severe Acute Respiratory Syndrome, CoV-2. It is a novel virus that originally got its name as novel coronavirus 2, then transitioned over to the new nomenclature of SARS-CoV-2. The novelty of this virus is really twofold. The first is that it is rampantly disseminating throughout the world, thus the designation of a pandemic, and also with regards to how it is easily transmittable. So there's a kind of epidemiologic term called R0, which is a capital R with a sub-zero. That tells how the infectability of the virus is, and the R0 value of SARS-CoV-2 is around 1 to 2 to 3, which means that if one person who has it, 2 to 3 who are around him or her will get the virus. Relative to other things, influenza is about 1 to 3 as well. Measles is 12 to 18. So the unique aspect of this virus has to do with how easily it's being transmitted throughout the world. So I wanted to present a couple slides with regards to that. And pictures are worth 1,000 words, so I wanted to be able to kind of present this data to the group. So this is from the CNN website, do let me know. So obviously the virus started in Wuhan, China, located by my cursor here, and has spread throughout the world very rapidly. And reasons for its spread have to do, again, with its transmissibility. So there's been a couple of questions with regards to, the aerosolized and stability of the virus. So I wanted to address that in these articles. So the first thing is that people had questions on was when how stable and how long does the virus live on certain desktops, for example, and certain metals and aerosolized particles as well. So this article looked at comparing this recent SARS-CoV-2 with the previous SARS-CoV-2. And again, the half-life in aerosolized, it was roughly about 1 to 2 hours, about 1 hour, very similar to the original SARS. And when they tested these two viruses on different surfaces, for example, like a desk or metal or plastic, they found that the stability of these two viruses were very similar. So I know one of the questions was how long do they last? That's why I'm addressing this now. So given the fact that they last for about 1 hour or so, they can actually then be transmittable with regards to that. So that's why there is a recommendation for surface cleaning, for example, with ethanol. So with regards to being able to remain viable for long periods of time, even up to days on some of these surfaces, that's why it's good to practice good hygiene at home with regards to wiping off surfaces. So the other thing that's unique to the pediatric patient population is this article, and that is that the kids will shed the virus. And the more immunocompromised that you are, the longer that you will shed the virus. Therefore, you are essentially a reservoir for the virus, and particularly the immunocompromised patient population. So again, picture is worth 1,000 words. Go right here. As you can see, with regards to taking serial rectal swabs from kids over days, you can see that is a very substantial amount of time that kids will actually shed the virus from the rectal area as well as from their nose or nasopharyngeal as well. So there's lots of variability to this, but this is the most updated data that we have. The other thing to kind of pay attention to with regards to the virus transmission is this article. So this article has to do with how you and I, or how other people who are asymptomatic for COVID-19 can actually still carry the SARS-CoV-2 virus. So therefore, we're asymptomatic. We don't yet manifest any clinical manifestations. We carry the virus, and so therefore we can transmit the virus. So these are the factors that have to give to that R-naught factor, that transmissibility. Asymptomatic carriage, a lot of prolonged shedding from the nose and from the rectum, particularly into pediatrics. These factors are the factors that really make this disease or this virus spread throughout the world. So when we ask, well, what happens in pediatric patients? How do they manifest COVID-19 signs and symptoms? And the classic 3 signs and symptoms are fever, shortness of breath, and cough. So the coronaviruses as a group are notable to cause respiratory symptoms, in particular lower respiratory tract disease. So those are the classic symptoms, again, fever, cough, and shortness of breath. And then with regards to what people are seeing as a clinician, we're seeing that a lot of kids will actually have these patchy ground opacities in the lung on lung imaging, and they will also need oxygen. But this is a key line here. So in contrast to adults getting COVID-19, kids tend to get less severe disease. Now, again, that's all kind of relative to the immune system of the child, but the vast majority of children actually do well with COVID-19 who have, with an asterisk, an intact immune system. So of the literature that's been published so far, this is a nice publication on pediatrics out of 2,143 patients. So again, a good general sample. And what this group has shown is that the vast majority of kids actually do okay. There is an infectivity, obviously, as the virus goes through the community. But for the most part, kids are spared from severe disease. So with that, I wanted to make sure that the group had very good resources or knew what resources to go to because of the fact that the information is changing so quickly. So the CDC website is an excellent resource to go to. This is what the face page looks like. With regards to looking at categories, they have everything here, and if you click on if you are at higher risk, that would be in this category, and the closest category that they have is children with, or people with asthma. This website actually goes through other things like disinfecting surfaces, and it also goes through what surface or how long and what you need actually to clean those surfaces. So this is a very good website. The WHO is a very good website as well. This goes through similar information and obviously has the most recent information with regards to the virus by country as well as its mortality rate. The other site that I don't have here is your state health department site. Obviously, that's specific to the state that you're in. That information is critical in terms of how many cases the state has seen, but we have to be mindful of reporting issues, and that is not every state has availability of general testing. The second thing is not every person is seeking medical care to be tested. And the third thing is not everyone has universal testing to really know the denominator of how widespread the virus is in their community. That said, the State Department of Health is an excellent website to get real live information near to you. So I lastly wanted to touch base in terms of this phenomena, or I shouldn't say phenomena, but this instruction of social distancing and why we as a medical community are mentioning that. So I have a couple graphs on this as well. So with regards to social distancing, this is a nice article out of the Financial Times. So this is just a pictorial representation that summarizes everything. So the number of cases and the healthcare capacity. So if we don't enact social distancing, if we don't enact closing large or shutting down gymnasiums or schools, we are burdening the future of the healthcare system, and that's what this graph shows. So again, the red hump is without these implementations. The blue, rather, is flattening the curve. So that's another expression that you hear epidemiologically. How do we flatten the curve? We flatten the curve by having an engaged community like yourselves, and we flatten the curve by people adhering to social distancing and what their their State Department of Health are telling them. So lastly, I wanted to show how rampant this virus is, again, throughout the world. Right here is the U.S. in terms of the number of deaths, and you can see we're following, hopefully, in South Korea. So South Korea has implemented a couple things, universal testing and austere measures in terms of social distancing. So hopefully we continue to have less of a curve in terms of viral-induced deaths other than Spain and Italy, which is amazing in terms of how rampant mortality is. So this gets into the new coronavirus case trajectories. As you can see, we're in the midst of the rest of Europe and the Americas. And as you can see, the Asian continents in terms of countries rather like Hong Kong, Singapore, and Japan, because they implemented social distancing and had engaged communities, their number of new cases of coronavirus and the trajectories are much less than in Europe as well as the Americas right now. So take-home messages, I think, are a couple things. Obviously, we're in a vastly new era right now, but don't panic. The last thing that you want to do is panic. Be informed, and you, as an audience, I know are very informed, but stay informed, stay on top of the information, adhere to social distancing, make sure that good personal hygiene is implemented, stay home if sick, and I know there are ramifications with your children on that, and we could talk about at the QA session, but in essence, the best way to do and to conquer this virus, to slow the pandemic, is by doing those things that I mentioned. So thank you for your time, and I'll have the next speaker talk.
Thank you so much, Dr. Auletta. I think that was really, really incredibly helpful information. We will, of course, include these resources on our landing page on the website so that everybody has continued access, particularly to these different tools and papers, so that you can go back and reread those more closely if you'd like to. So again, thank you, Dr. Auletta. That was just really wonderful information. At this time, we'll hear from Dr. Seth Perlman, who is a neurologist at Seattle Children's Hospital. Dr. Perlman really is in the thick of it out there in the Pacific Northwest. So we look forward to hearing a little bit more about what he has to say.
Great, thank you. So like you said, for us up here in Washington State, we're kind of the hotbed of active COVID infection at the moment, and things started earlier for us than I think much of the country. And just like Jeff was saying, I mean, it's really been an evolving thing that we've all really kind of needed to try to get as much information as it comes out as possible. But as the pandemic has unfolded, it's been hard, especially in the earliest days, to give a lot of concrete advice, given that there wasn't a lot of evidence for lots of the questions that are out there. As far as what our experience and sort of what we've been learning in Seattle and in Washington, so in our state, we've as of yesterday's sort of public health reporting, we had just under 1,200 COVID cases in our state and 66 deaths. Really, as far as the patients that have gotten the sickest, they're all older adults, and the majority of the deaths in our state actually were associated with a single nursing home. What we've actually not been seeing, which hopefully continues to be the trend, is a lot of COVID disease in our pediatric age population. And including, I haven't so far seen or heard of any patients with DMD or other neuromuscular disorders that have been tested positive for us at this point, which I'm hoping continues to be the case. And at our hospital at Seattle Children's, we've actually, from sort of what's been out in the news, it's been a low number of cases that have come back positive. At the moment, per news reports from yesterday, we had 4 cases total, 3 of whom went back home and were recovering okay, and one that was, as far as I know, just in an isolation unit, but not in the ICU necessarily. So right now, it seems like we're kind of following along with what Jeff was talking about in terms of the youngest patient seeming to not be the most severely affected. What's unclear is whether, kids are overall going to be less likely symptomatic or seriously ill, or is it just, is this partially because we've only been testing symptomatic kids for the most part, and there may be many kids that are asymptomatic or so mild that they don't present to attention. What we have been doing, and kind of in response to what we see happening around us in the community, are a lot of systemic changes that affect everyone's day-to-day life and care. On an institutional level and in my clinics, and all of us that take care of the neuromuscular and DMD populations, we've really not been doing any more face-to-face routine visits in the midst of this, and really been postponing any non-urgent in-clinic evaluation. Elective procedures are something that we're postponing as well, and we've been doing very relaxed limitations on delivering clinical care through electronic means, either just over the phone by talking with parents and families. And in our multidisciplinary clinics, we've actually been really just kind of setting up appointment times, putting the team, for example, myself, one of our rehabilitation medicine specialists, pulmonologist, on speaker with parents at what would have been a normal clinic appointment time. We've also been pre-screening the kids that are scheduled in the coming weeks to come into our multidisciplinary clinics by reviewing their charts, having nurses reach out to families to make sure that there's no urgent thing that would require them to come. And if not, then we tell them to stay away from the hospital and stay away from coming into clinic. As a hospital, and I think a lot of institutions have been doing this, really limiting visitors and how many caregivers can come, screening patients and staff to see if people are symptomatic, and trying to limit kind of access to the building itself as far as cutting back some of the entrances that can be used. And all of that is really geared towards both trying to protect the patients in the hospital, trying to keep people that may not have been exposed to the infection from being exposed, and trying to protect all of the caregivers and medical personnel involved. And just like Jeff was talking about, the social changes have been huge in our area too. So the social distancing is something that all around people have been taking very seriously. In our state, the schools have been closed since I think last week. And that's including grade schools. The University of Washington is only doing remote classes. All the restaurants and bars and other things like sort of entertainment venues are all closed, except for takeout or delivery, and there's no public gatherings or events happening. So both the kind of in-hospital and clinic changes have been huge, as well as just the greater society changes. And really what we've sort of been learning from this and having to adapt to are these huge changes, both to daily life for patients and families, as well as medical providers and everybody around, and really having to evaluate how we're delivering medical care in the face of this, and really having to make some pretty rapid and significant changes from the norm and what everybody's used to try to flatten that curve and try to prevent overloading the medical system with so many cases that would come up all at once. And really, I mean, there are these different at-risk populations, and for our muscular dystrophy community and people on immune suppressants, that is definitely a big worry. In practical sense, it seems like around Seattle, it's continued with the trend of what's published out of China, where it's really been adults that are hardest hit. And a lot of hospitals actually reaching capacity to the point that our hospital has started advertising that we can accept pediatric patients from other hospitals if they need to open up more beds for adult patients who are sick with this infection, or even accepting new patients that are still in very young adulthood because more beds are needed in the adult facilities in order to accommodate the increasing numbers of sick older patients with COVID. So there's been a lot of adaptation that's been needed and a lot of learning that we've all had to do. And sometimes really kind of on the fly, just because much of this is unprecedented and not things that we've had to deal with before. But there's lots of things to learn is basically the bottom line, and lots of adaptation that's been needed. So I can turn things over to the next speaker.
That was great, Dr. Perlman. Thank you so much for your perspective. I think you have a bit of a unique perspective considering where you're located, and I think a lot of us in other parts of the country look to you and your institution and your city to see how you're handling these things, and I think it's a great guide for us as this continues to evolve. So thank you so much for that perspective. Dr. Kathryn Wagner from Kennedy Krieger is a neurologist as well. Dr. Wagner, maybe you can tell us a little bit about the recommendations that you're making for your patients and some other considerations that we should keep in mind for our patients from that neurological perspective.
Sure. Good afternoon, everyone. I think that boys with Duchenne, many boys with Duchenne are at increased risk for contracting the coronavirus and are at increased risk for severity. And there are two aspects of this. One are the kids on corticosteroids that lowers their immune response. And perhaps more worrisome are the kids and adults with respiratory insufficiency. And I think that if your child falls into one of those categories, that you should seriously consider isolation techniques. So, for instance, not having play dates for that child or for other children in your family, seeing whether the parents can work from home. If you have a home health aide coming in, talking to them on a daily basis about their health, just really reinforcing that they need to be washing their hands before any time they touch your child. The other recommendations are just standard that you've heard before, but frequent hand washing for everyone, keeping your hands off your face, disinfecting your surfaces a couple times a day at least. And then I wanted to talk, so those are preventative measures, but then I wanted to talk to you about what to do if your child got sick. So not everyone who gets sick develops gastrointestinal symptoms, but a certain percentage do with vomiting and diarrhea. And it's critical that if your child gets sick, they receive daily corticosteroids because of the risk of adrenal insufficiency. And so first, if your child is on weekend dosing and they get sick, they need to receive a daily dose, and you should talk to your neurologist about what that dose should be. If they can't keep down their corticosteroids, then they need to be given corticosteroids intramuscularly. And the common drug that is given intramuscularly is called Solu-Cortef. And I would recommend that everyone get that from their pharmacy now, not that they wait until their child is sick, but have that on hand. And again, that's something that your neurologist would prescribe for you. So again, you only give it if your child is not keeping their corticosteroids down, and then you inject it intramuscularly into a big muscle like thigh or upper shoulder. And if the next day your child is still not keeping the corticosteroids down, you can re-administer it, although I would begin to be concerned if they're vomiting for 2 days, they may be getting dehydrated and need to come in. The other issue, as I mentioned, is respiratory insufficiency. If your child has we're gonna get that more from Dr. Schell about how to treat respiratory insufficiency in the setting of coronavirus. So I won't go there, but let me just say, because I had one patient already get intubated because they were put on oxygen and without ventilation, that you just have to reiterate to any emergency department physician that if your child has respiratory insufficiency, they cannot get oxygenation without ventilation. So they need, for instance, a BiPAP, not just oxygen, because that will encourage them to stop breathing. I think that I will stop because other recommendations I have are mostly pulmonary, and I'll let the pulmonologist, Dr. Schell, talk to you about those.
Great. Thank you, Dr. Wagner. I think that's a great segue into time with Dr. Richard Schell from Nationwide Children's Hospital, who's a pulmonologist. So, Dr. Schell, if you'd like to share with us some information about pulmonary considerations with COVID-19, that would be wonderful.
Great. I'm happy to, and I know that at the end of this we're going to have some time for questions and discussion, and I think that the most important thing is not to be alarmist in this. However, I do believe that patients with Duchenne muscular dystrophy who already have respiratory insufficiency are probably at baseline at higher risk overall. However, I think there's no data to suggest that we treat this infection, at least in Duchenne, any differently that any other serious virus could cause the same problem. So if you are already a patient who uses BiPAP or has low pulmonary function test and you get influenza or you get RSV or you get another form of coronavirus, which all of these viruses are out there, I got a lot of pre-questions about, like, how should we treat this differently? And there's really no difference that I know of except for supportive care. And I totally agree with Dr. Wagner that the idea of oxygen out there is a critical one. You know, patients with respiratory insufficiency should not just be put on oxygen without close monitoring. We need to figure out why the patient needs oxygen. So if they're having respiratory insufficiency and they already use BiPAP, you should be using your non-invasive ventilation to help you breathe, and not just be in an emergency room where, your saturations are low and you put on oxygen. There may be some instances where oxygen may be used without BiPAP, but if you are finding yourself in a situation where you or your child's oxygen saturations are low, I think it behooves you to be their advocate and use the word BiPAP or use the word ventilation, or really push the doctors taking care of you to make sure they understand, that obviously they need oxygen, but shouldn't we figure out why they need oxygen? So with that saying about oxygen, I think from a pulmonary perspective, again, the most important part in my head is prevention. And again, following the guidelines about hand washing and social distancing and staying out of school, especially if your schools are not already closed, is important. I would also say to, again, cancel all non-urgent appointments, both in the hospital or if you have therapists or people that come to your house to provide therapy, I think those should be postponed as well. I think that the other thing that, could be important is to just be more prudent about washing down all of the different equipment that you may use, including wheelchairs and things like that. I think even if you don't think anybody else has touched the equipment, it's probably a good idea to wipe that down. Looking at equipment that you may have at home, if you have a cough assist at home and are using it daily, please don't stop. However, if you have one at home and you're not using it daily, please get it out of the closet and try to get familiar with this again. I'm sure that your local teams, if you call, can at least over the phone go through specific, settings that might be appropriate for you or your child. I think that I tried to find out online, but washing this equipment, you don't want to wash the filter part of the cough assist, but you can certainly wash the mask and the tubing with mild detergent and letting that air dry. I believe it's also okay with a vinegar and water solution, but theoretically only your child or you are using that device, so just making sure it's clean and dry is important. I see the cough assist like brushing your teeth every day, and this is there to help prevent illness. And when you're sick, it's the best way to stay out of the emergency room. However, I'm sure there's many people online that don't have a cough assist, and I don't want people to panic and think they have to go out and get one. There's no urgency to getting a cough assist if your child already has good lung function, and that may be the reason you don't have one. If your child's lung function and their cough strength is good, which is something that we follow in clinic, a cough assist may not be needed on a chronic basis. However, if you should happen to be admitted to the hospital and that you're having distress or your child's having distress, then a cough assist is definitely something that would be helpful in that situation to help clear those secretions. At least in our center, ordering a cough assist is based on lung function and symptoms. And we're pretty proactive about getting that. But again, I don't want everybody to think that they need to go out and get a cough assist, because having a cough assist is not going to prevent you from catching this virus. It is just a device that is in place for patients who have a weak cough and can't clear the secretions. So it might be a good, if you have other questions, certainly speak with your team or your pulmonologist on that team, and they can try to help explain if you need that or not. But again, if you do have one at home, this is my chance to really push the cough assist. I'm a big fan of it. Please get it out, dust it off, and use it so that you understand how to use it in case you have to use it in a more urgent situation. The only other thing that I wanted to talk about before we take questions really is that if you or your child is using BiPAP at home or is already on non-invasive ventilation, please continue to use it as prescribed. There is no need to have a BiPAP machine at home if it's not needed, and I think that it would be more dangerous to use this at home acutely without being monitored. One of the questions that I received was, would it be a good idea to have BiPAP at home just in case? And the answer is no, there's not enough BiPAP machines probably to go around for that. And two, I would never want a patient to start BiPAP on their own at home. And if you really feel like you're having distress and you need more support, that you need to get to the emergency room more acutely. If you are sick, please call your local team and get their advice as to being evaluated in a clinic situation or going to the ER. I know many clinic situations are being postponed, but there are quickly arising availability of telehealth. And, at least here we're not stopping all involvement with patients. If people need to be seen, we're going to see them. And then the other questions we got about was really treatment of this virus, and I don't believe, and other people can correct me if I'm wrong, but the treatment for this virus, if you're sick, is the same as for any other child or adult with Duchenne. Like if a child or adult needs support, we're going to provide support. There's no different ventilator strategies for this disease necessarily. It's really a clinic person-to-person basis. So I think that supportive care, if you're in the hospital, is what's going to be given with just a lot of extra gowns and gloves and masks. So with that, I'll stop there before I ramble on too much. And I think I made all my points, but go ahead.
Dr. Schell, this is Kathryn Wagner. Please comment on the frequency of using cough assist when you're sick. We are telling patients to use it every 2 hours if they develop symptoms of the coronavirus.
Thanks. That's a great point. If you have a cough assist at home, I usually ask patients, at least in my clinic, to try to do it twice a day, kind of like brushing your teeth on a preventative basis. When they have the very first symptoms of any illness, and this goes for any illness, not just the COVID-19 illness, I ask them to increase that to 3 times a day, to 4 times a day. Doing the cough assist every 4 to 6 hours can be tedious, but it can absolutely prevent you from, ending up with pneumonia. And, my guess is that I think in this type of situation, to help prevent people from needing to be in the emergency room, it would be very prudent to do it every 2 to 3 hours at home. I definitely, for patients that are admitted to our hospital, if they're in the hospital, we definitely do it every 2 to 3 hours. But if you think about having an illness and coughing, there's no harm to doing it. What I'd like to know is, like, if you're doing it every 2 hours and you're still not improving, that's definitely, a reason to call your local providers and get further advice.
Thanks so much, Dr. Schell. I think it's really helpful that you reiterated, the importance of communicating with your local teams. So oftentimes these situations can be very individual and specific to the patient. And we want to make sure that you are using the guidance that we're providing you today, but more so really communicating with your team if your child does get sick to make sure that those recommendations are specific to that particular situation. If you do find yourself in the ER and a physician does try to prescribe oxygen, Dr. Schell did mention the importance, and Dr. Wagner as well, of using that oxygen in the context of BiPAP, but that information is also on our emergency card. So I would encourage those of you who don't have one to also go ahead and take a look at our website for that information as well. So at this point, we'll go ahead and dive into some of the questions that we've received. So these are some good general information questions that we received. So maybe Dr. Auletta, you can start off with the question, can this virus reinfect the same patient if they've already contracted it and recovered? I think this is something that a lot of us are curious about.
Yeah, that is actually an excellent question. And unfortunately, I don't have the answer. So I have a presumptive answer based upon the epidemiology. So people have probably heard some good news out of China that they have not had any new cases. I don't know, that came out yesterday, so that's good news. And we have to believe what's coming out of China is authentic. So assuming that is, I have nothing to feel that it isn't, that would tell us the answer to the question. So if in fact people were susceptible for a reinfection, then I would have assumed that there would continue to be active infection in China. Do we have evidence of that in terms of serology? In other words, taking blood from a patient and measuring an antibody response and then correlating that antibody response to protection against disease? The answer to that question is no, but there's open trials for that. But again, based upon no new cases out of China, the presumptive answer is no for reinfection.
I think that's really reassuring for all of us. So this next one I think is really helpful too, and I myself I think have seen kind of varying answers, so I'm not sure that there's a clear answer. Maybe you can clear it up for us. How long is the virus airborne, and how long does it live on surfaces?
Yeah, great question. So that was one of the studies we reviewed. Again, this is a one-study thing, but based upon, in terms of aerosolized, at least an hour is aerosolized, and then on surfaces can be hours to days, depending upon the surface. So as one of the physicians had mentioned, that's where it's really important to, and again, I get this. I come from an Italian family, so if you tell an Italian grandmother to clean surfaces, you're going to get it like 150 times a day, but well within the reason of at least once a day in terms of common contact surfaces, in terms of using ethanol-based products. And again, the CDC website has a great disinfectant category in terms of how to, make the disinfectant. If you don't have alcohol-based products, you can use diluted bleach-based products, but be obviously very careful with bleach in the house.
That's great. And I think this next question is for both you and for Dr. Schell. I know we're seeing some information that perhaps after somebody recovers from COVID-19 that there might be residual lung damage or decreased lung function. And to speak to this question, there's concern that perhaps there would be lasting kidney damage. Do we know what that looks like and if that's true?
Would you like me to take it first?
Sure.
Yeah. So with regards to end organ dysfunction, so there's this disease spectrum that we see with the SARS-CoV-2 virus. Again, kind of like asymptomatic carriage, where I mentioned that those people out there don't even know that they harbor the virus. They just carry it in their nasopharynx or nose. To mild disease, where the virus is causing symptoms, to severe disease, and that severe disease means the intensive care unit for those patients, and they often are on mechanical ventilation because of the changes in the lungs and causing something called ARDS, or damage to the lungs. So with regards to knowing the disease spectrum, we expect those patients who are at that far end of severe disease to have end organ dysfunction. And so what do we mean by end organ dysfunction medically is problems with their kidneys and liver, and they could go into organ failure because of that. That's very extreme. And again, if we look at the literature, that's mostly in older adults with comorbidities. In other words, greater than 55, have heart disease or COPD or things along those lines. So we don't yet have, well, we do have reassuring information in pediatrics. Do we have anything specific for cancer patients? No. Do we have anything specific for Duchenne's patients? No. But again, my pediatric cancer patients and your kids fall into the bucket of pediatrics. And you just heard from Dr. Seth that in the heart of it right now, the epicenter of Seattle, where there's a high prevalence of this disease, so far so good, knock on wood, in terms of pediatric patients, and again, in terms of those immunocompromised patients.
I think we all find that really reassuring, and that really addresses that last question on the slide there as well. So thank you so much for that. That's really, really helpful. We did get quite a few questions about steroids. So maybe Dr. Perlman and Dr. Wagner, you two can talk about these things. And maybe we could start off by revisiting the indication for stress dosing steroids, when we should do that and how we should do that. That is something that was covered in our FAQ document, but we can review that important information here again. And maybe Dr. Wagner, you could also clarify the concept of transitioning from weekend dosing to daily dosing and stress dosing, and what that situation looks like, just for clarity for everyone.
Sure. So when someone who's on corticosteroids gets sick, they need to have corticosteroids every day, and they may need a higher dose. That's really dependent on the dose that you are receiving. Many boys are receiving doses that are already considered stress dose steroids. So that's something that you should talk about with your neurologist. And one way in which the weekend can be converted to the daily is to just take what your total Saturday and Sunday dose is and to divide it by 7. However, again, your neurologist might want to give you a higher dose than that for a daily dose if your child got sick, which would be more in line with stress dose steroids. The second question, I think, is really important here. Are steroids safe to continue? It's absolutely imperative that they continue. This is not a time where you would want to try to taper your child off steroids, because that takes quite a bit of time. You have to check frequently whether your adrenal glands have kicked in, and this is absolutely not a time to taper someone from steroids.
And I would just want to add to what Dr. Wagner was talking about, sort of going back to the stress dose topic for a moment. A lot of that is going to also depend upon the severity of illness of a child and whom that's being considered. If a child with Duchenne, for example, got COVID, and if it looked like it was in line with what most of the young patients seem to have, which are mild symptoms, it may not require, as long as they can tolerate their normal, like if they're on an everyday steroid regimen, there may not need to be any changes made at all, because that may be sufficient. And I think that looking at that P.J. Nicholaff steroid protocol is really helpful for families potentially, especially if you're dealing with providers that aren't as familiar with steroids in Duchenne, to maybe point providers to, in order to get some guidance about whether steroids need to be adjusted at all, and whether the daily dose that your child is on is sufficient. For example, if a child did get really ill and needed to be in an ICU or was extremely sick, they may actually then need additional steroid dosing on top of what their daily regimen is. So a lot of that's going to depend on just how severe the illness is when the question comes up.
Absolutely. Thank you for mentioning the P.J. Nicholaff steroid protocol. That will be available on our landing page on the website, and is also already available on the website on the steroids page. And for those of you who are parents or patients, your physicians probably have that steroid available as well. So really important to keep that in mind and at the ready if you were to become ill. So we're going to jump to hospitalization and treatment. If I can make my slides work. Oh, there it goes. Okay, here we go. So these are a lot of questions that surround the potential, if someone with Duchenne were to become ill with COVID-19, what hospitalization and treatment would look like. I think the answer for some of these questions might depend upon your institution and their specific protocols and rules surrounding hospitalization. But I do think that we've got a lot of expertise on the phone that could give us some guidance for what these look like as well. So let's just start at the top. If my child were admitted to the hospital, would they be in isolation, and would a parent be allowed to be with them, whether for COVID-19 or for other potential infectious reasons? So maybe Dr. Schell and Dr. Auletta, you could tackle this one to start, and then we can see if we've got any additional comments from Dr. Perlman or Dr. Wagner.
Go ahead, Richard.
You might actually know the better protocol. I mean, I would assume that if a child is admitted to our hospital here, they would absolutely, I know they would be in isolation. We have a new protocol right now that all children who have the risk factors that have been published will be tested for COVID-19, and they will be placed in isolation. If the test is negative, they will be taken out of isolation for COVID-19. If it's positive, they'll be moved to a special unit in our hospital. I don't know if I have the exact answers about visitation, but I'm pretty sure I read that we're allowing one visitor.
Mm-hmm. Yeah. So Richard, you're spot on. So everyone expect that there will be visitor restrictions at the hospital that you go to. Those visitor restrictions could be as stringent as only one parent, or they can allow two parents, but that's it. There will not be any kids allowed to come into the hospital. There will not be any more than two visitors. And as Richard mentioned, they will usually be put in a cohort of other respiratory viral patients for SARS-CoV-2 rule out. And what that means is in a negative pressure room, so that the air is, taken away versus being kind of pushed out. Dr. Seth probably has some more insights in terms of what they're doing in Seattle right now, given the high prevalence.
Yeah, definitely the visitor number is restricted. And I think that's probably one of the big things that impact, families as a whole if a child does get admitted. And that's kind of across the board, regardless of the reason for the child coming into the hospital, is that there's going to be limitations on how many visitors there can be and how much family can be present with the child at the bedside. Like I said, we've actually had a really low number that have tested positive at our institution for the virus. So I haven't so far, knocking on wood, had to deal with any of our neuromuscular patient population actually coming in and sort of what their pathway in would look like. But I think the big impact on everybody, regardless of why they're coming in, is going to be visitor restrictions.
Great. Here's a question, kind of a follow-on question to that. So if a patient were to go to the hospital for COVID-19, and hopefully we don't have to deal with that, but, I think it's good to at least be prepared and consider these things. Is there anything beyond the emergency card that we would want to tell our healthcare providers if we take our child to a center? I know a lot of our certified Duchenne care centers are very familiar with this patient population, but what if we find ourselves at a county hospital or an outlying institution?
Can I start with that?
Go ahead. I was just going to say, I think the emergency card covers most of what would need to be communicated, including that the child is on steroids, if the child has respiratory insufficiency and therefore needs ventilation with oxygenation. I would encourage the hospital to call the muscular dystrophy team that is taking care of the child and coordinate a response and be familiar with the child's underlying health care.
I was just going to add to be yours or your child's advocate and make sure that you alert the nurses and doctors caring for you in the emergency room that if you are on in non-invasive ventilation at night, that you have it. Like, make sure you're telling them this is what you've been doing at home already. I think that one thing that I thought of after I answered the question about doing the cough assist frequently at home, which I totally agree with, but this is from a end organ standpoint, like patients with Duchenne muscular dystrophy have normal lung parenchyma, like the inside of your lungs, for the most part, unless you've had lots and lots and lots of infections, is essentially normal. The lung function is lower because you have a restrictive disease and your muscles are weak, so they can't take as big a breath. So there's more of a insufficiency. I think that it's important that if you're sick at home and you're doing the cough assist every 2 hours, most likely those muscles are going to get much more fatigued when you have a viral illness. So I think it's very important to be closely monitoring at home if you're truly needing that much support, and call your team and get advice as to whether or not you should go. But if you are in a more local situation, make sure that you hand them that card if you have it, or tell them how to find that on the internet, or how to get a hold of your doctors. But make sure they understand that you're on BiPAP or you have a cough assist at home. And, if you know what your PFTs are, that sometimes is helpful too.
That's fantastic. And I think you kind of even touched on whether or not someone should go to the hospital or be treated at home. I think it's probably prudent to follow those symptoms. And if things become more concerning, then that would be a necessary indication to go to the hospital, but probably try to stay at home as long as possible. Would you agree with that?
Yeah.
Great. So the next couple of questions have definitely been a hot topic as of late, particularly the contradictory advice between the World Health Organization and the European Medicines Agency about the use of Tylenol. So maybe, Dr. Auletta, you could speak to the use of Tylenol and then even prophylactic use of chloroquine and hydroxychloroquine and some of these different medications that folks are suggesting might be helpful or even dangerous.
Yeah. So, okay. Excellent question. So the first thing is that I believe the controversy is more about ibuprofen than acetaminophen. But here we're not necessarily discouraging ibuprofen. So a lot of this has to do with the SARS virus kind of driving inflammation in the body. So obviously acetaminophen is an antipyretic, so it deals with fever. Ibuprofen is more of a anti-inflammatory, but obviously has been used for fever as well. So currently our hospital policy is indifferent in terms of the use of acetaminophen or ibuprofen. I think that it does get into a little bit of, if you're on that spectrum that I talked about earlier in terms of more severe disease, then we as physicians will probably not give ibuprofen, and if there's any kind of liver insufficiency, not give the Tylenol or the acetaminophen. The other thing that
sure, go ahead. Add there that because most of these kids are on corticosteroids, ibuprofen is not really recommended in addition to corticosteroids in general. So it would be preferable to use Tylenol.
Mm-hmm. With regards to available antiviral medications, unfortunately, we do not have any FDA-approved medications for COVID-19. So you have to think about the virus itself in terms of the types of medications that would potentially work. So the virus has a single strand of RNA to it. It's similar to what HIV would have. And so HIV and SARS-2 require a host cell to go into, and then once it enters the cell, it takes over kind of the reproductive aspects of the cell through the DNA so that it can replicate itself and that it can make these proteins that can package the virus. And then it leaves the host cell on top and then goes on to the next cell. So currently, based upon, again, the analogy to HIV, some people have used HIV drugs, something called lopinavir or Kaletra. And also, there is another drug called remdesivir which is in early phase clinical trials. So when we looked at some of these drugs, the field itself, when we looked at some of these drugs outside the body and actually used them in animal models like mice, the remdesivir is the most promising. So remdesivir is an antiviral protease inhibitor, again, in that quote-unquote HIV family. And so the company is in early phase of this. So they had this early phase trial going on. So as you can imagine, if it's not FDA approved, people are going to the FDA to release the drug on an emergent basis. But it's only being released for people who are pretty far on that spectrum that I mentioned, with severe disease, who are on a respiratory machine in the PICU. So based upon that meeting the criteria, certainly we wouldn't want to have to get to that point to use the drug. So another thing that's kind of going on in the background, you guys have probably heard about Dr. Fauci, and he's in charge of this institute in the National Institute of Health called the NIAID. And so he's been with President Trump on numerous press releases and all. And Dr. Fauci has the potential to ask the FDA to fast track a drug. And so that might be going on right now, that they're trying to fast track this drug with the amount of data that they have from this early phase clinical trial to use it, rather than further on down the spectrum, but sooner in patients. So a long answer to the question, but I just wanted to give a perspective. I see that there's hydroxychloroquine and chloroquine. There's been some studies out of China who try to do just that, use it as prophylaxis, and they haven't been very successful. And so my last point is definitely, we'd like to have an antiviral, but the best thing we would want is a vaccine. And the vaccines take time to develop, and then you have to test them for safety. And so probably the earliest vaccine is about 12 to 16 months away. That assumes all goes well in terms of its efficacy and its safety. So in the meantime, the field is trying to work diligently in terms of fast-tracking an antiviral, making sure it's effective and safe, and then also with regards to developing a vaccine against SARS-CoV-2.
That was a really helpful overview. I know I just learned a lot. So thank you for that, Dr. Auletta. The last question we have on this slide is regarding bed space and hospital capacity. And I don't know that there's a clear-cut answer to this, but perhaps just some general perspective could be helpful. So what would happen if there weren't enough beds in a children's hospital, and would those patients be transferred to an adult facility? And I think you did a great job reviewing the fact that, this really isn't something that we're seeing in the pediatric population. And I honestly am curious if perhaps we would see the converse, running out of beds in adult facilities and maybe needing to spill over into a pediatric facility. But maybe Dr. Perlman and Dr. Auletta, you could comment on that.
Yeah, I think, like you just said, what so far our experience has been here, it looks like it's more the opposite, that it's really the adult medical facilities that are kind of overtaxed and at capacity, and the spillover, is bringing patients that are on the young side for their populations, but a little bit older than we typically see coming to the children's hospital instead of going to the adult hospital. So right now, we've not had any experience where we're running into problems where it's actually that the children's hospital is full and needing to send patients elsewhere. It is the opposite situation at the moment.
I really don't have anything to add because Dr. Seth is in it, right? And so he's going to have the best perspective, for the answer to that question.
That's fantastic. I know that we are running a bit over time, and I think that was really helpful, all of it. And so we weren't able to get to all of our questions. So I have to apologize to the audience that we just had so much great conversation. We weren't able to get to some of the last questions today. But we will absolutely try to address those and then update that FAQ document on our website. Please know we're going to continue to update that as questions come in and really answer as many of those as possible. We did get a handful of questions about clinical trials and cardiac medications, particularly ACE inhibitors and ARB medications. I want you all to keep an eye out for future webinars that we have in the works to address these questions. So please continue to keep an eye out for emails and check back on our landing page as we firm up plans around those additional webinars. So as I also mentioned,
Rachel,
this is recorded.
Sorry, Rachel. Could I just address one question, which is a common one from my patients?
Sure.
And people, I just don't want people getting the wrong information. There has been some talk that ACE inhibitors are contraindicated for coronavirus, and that is not true. So your children should continue on their ACE inhibitors or their angiotensin receptor blockers.
Thanks, Dr. Wagner. And you're absolutely right. There have been so many questions, and we're definitely going to dive deeper into that next week with a webinar with a couple of cardiologists. So I would encourage everybody to tune in, and we'll, like I said, dive a little bit deeper into the literature and the data and what it has to say. All right. So at this point, I am going to go ahead and wrap things up. As I mentioned, this is recorded and will be available online for you to go back and listen to, share with other families and friends that might be interested. So again, we thank everybody for joining us, and we hope you all stay safe and healthy and well, and continue to use those social distancing precautions that we've gone over today. We hope this was helpful for you, and just thank you for joining us. Everybody have a great day.